I will talk about does choice of antiretroviral drugs matter for inflammation. Antiretroviral drugs has deeply changed the natural history of HIV infection. We have seen also from many presentations earlier this morning, and there is an increase in survival, which is still going on in the most recent year. So the better has also to come. But what we see, what we face in our everyday clinical practice, in our ambulatory, is that our patients are affected by many comorbidities. And this happens 10 years before the general population. This is a paper published by Giovanni Guaraldi, who is working with me in Modena. And you see that the same numbers of comorbidities are present in HIV positive 10 years earlier than in HIV negative. So why all these comorbidities? Obviously, the lifestyle has plays some roles, but also what is now the main characteristic of HIV infection is that HIV infection is a chronic inflammatory disease. And we have the inflammation linked to HIV replication. It mainly happens when you are in the absence of antiretroviral treatment, but also in patients who are treated with HIV infection, there is a low level of HIV replication that is going on despite antiretrovirals. There is microbial translocation due to the gut damage, which happens soon after HIV infection, viral co-infection like cytomegalovirus or HCV, comorbidities, and as I said, lifestyle factors. But why is chronic inflammation harmful? Actually, we know that inflammation is, for example, at the basis of atherosclerosis plaque. So it's important to understand that many of the comorbidities which affects our patients are due to inflammation. And this has been perfectly shown with a method that is the PET scan, showing that in patients with HIV infection, the vessels, the big vessels like aorta, for example, are really much more inflamed than in the general population, than in an HIV negative subjects. And if we use as a proxy of inflammation intima media thickness, we see that despite the use of active antiretrovirus and an undetectable viral load, the level of intima media thickness in patients who are undetectable on antiretrovirus never reaches the level of HIV negative subjects. So the only instrument that we have in our clinical practice is antiretroviral therapy. So what we could do, we could at least start earlier, as early as possible. So will early ART normalize immune function and health? Actually, there has been some data on primary HIV infection, patients who were diagnosed very early in the course of infection. You see 12 days, 16 days, 18 days. And what you see is that apart from one patient, all the other could not reach the level of inflammation expressed as soluble CD14, that is the ligand of LPS, as the of the HIV uninfected. So they are better than the chronic HIV on ART, but they never reach HIV uninfected subjects. And even a huge trial as the START trial has shown that actually, despite what maybe we were thinking before the trial, I mean, the idea was that patients could have been affected more by non-AIDS events than from AIDS events, but what we have seen was really that the early ART was protective for AIDS event, but not really for non-AIDS events, apart from cancer, as Mark Bauer said this morning. So you see that if we look at the cardiovascular outcomes, cardiovascular event, really no difference was seen between those who started early or those who start late. So, but one problem that we have in clinical practice is how can we measure chronic inflammation? And this is really not easy, because the biomarker that has been associated better with prognosis and especially with mortality was IL-6, as you can see from this study. But also, more recently, there has been the soluble CD163 that was related to mortality. And at CROI this year, we have seen the SUPAR, which is another marker that was related to non-AIDS events, and CL13 that was related to non-AIDS cancer. So all these biomarkers are very interesting, but what really makes them play the same role, it's really in common among all of them, is that they are impossible to be performed in clinical practice. No one of us could have access to these biomarkers in our everyday clinical practice. They are complicated, expensive, and so they could be validated in big cohorts, but it's not something that we could say to our patient, oh, your SUPAR is increased, so pay attention to non-AIDS events. So a couple of years ago, we have published with ICONA cohort a marker that is actually much easier to have in clinical practice, that is the CD4-CD8 ratio. And what we saw was that in presence of an undetectable viral load, the CD4-CD8 ratio, especially when it's below 0.3, was associated not only with AIDS events, but also with non-AIDS events. So this is very simple to see, and this probably is because it's a proxy of a high level of CD8, which is a proxy of inflammation. The same marker was studied earlier this year at the CROI by in the STAR trial, and they compare IL-6, D-dimer, and the CD4-CD8 ratio, and they want to see which one of them was had a more prognostic role for the development, for the onset of events. Okay, either AIDS or serious non-AIDS events or death. These are the events shown in the START trial. And what we could see is that actually, as IL-6, that was already known, as I told you, D-dimer and CD8, but also CD4-CD8 ratio were independent risk factor for the development of events in the STAR trial. This was true when they were considered alone. This was true when the analysis was adjusted for one for the other. You see IL-6 stays significant when it was adjusted for CD4-CD8 ratio, didn't stay significant when there was the D-dimer. D-dimer stays significant with in all three cases, and CD4-CD8 ratio in all three cases. So it was really validated even in a big study as the START trial. So my title was about antiretrovirals. So we don't have a very, a huge number of data on antiretrovirals. But if we go to the ARDENT study, that is the ACTG 5257, where that studied atazanavir versus darunavir versus raltegravir, what you could see is that if we look at the biomarkers that were published on CID, you see that really the trend in biomarkers, either with atazanavir or with raltegravir or even with darunavir, is really the same. These are the different biomarkers. Some of them are a little bit increasing, some of them are decreases, but if you look at the graphs, they are really, really similar. And when we compare one with the other, you don't see any difference between atazanavir and darunavir, atazanavir and raltegravir, darunavir and raltegravir. When you talk about CRP, IL-6, D-dimer, soluble CD14. So it's just, So for these three, it's not easy. Earlier, last year, it was published this paper by Sergio Serrano Villar, who is working in Madrid. He did an analysis on CD4-CD8 ratio in the start Merck when there was the comparison between efavirenz and raltegravir. And what he showed was that the CD4-CD8 ratio increased more in raltegravir arms, but only in the stratum 0.4. So probably the effect on the rapid decay of viral load increases the CD4-CD8 ratio in those who have a very low CD4-CD8 ratio more rapidly than in the other, than in those with a higher ratio. The last datum on this specific drug is this datum that was published last year by the group of Jacqueline Capot in Paris. What you could see is that in vitro, they look at the Maraviroc integrase inhibitors, dolutegravir or raltegravir, and darunavir as a protease inhibitors. They look at the cell function, inflammation, and senescence using in vitro endothelial cells. So what you could see in this graph, especially if you look at SCAM or VCAM, that are inflammation molecules that, goes for the inflammation of the vessels. What you could see is that compared to the control, raltegravir really doesn't do anything, while maraviroc and dolutegravir determines a decrease in this level of inflammation. So if raltegravir doesn't do anything and dolutegravir is doing something, we are talking in vitro. So something completely, that has to be shown in vivo. Probably it's not a class effect of integrase inhibitors, but it's more specifically a drug effect of dolutegravir compared to raltegravir. But it's not nature medicine and it's not in vivo, so it's just, we will see, but it's really interesting. So what about new strategies? I talk about inflammation, I talk about what single drugs could do, and maybe the things are really a little bit disappointing. We don't see any specific strategy to target inflammation with antiretrovirals at present, but we have new strategies. Just the first thing that I want to say is that what happens if you are continue to take 3 drugs. These are the new data published by the RCC collaboration on almost 40,000 patients, just to show you that if you continue to take 3 drugs and you continue to be undetectable with the viral load, what's happened to, independently from the baseline CD4 that is 50 to 99, 100, 200, 200, 300, and 50, 350, 500, plus than 500. If you look at CD4, CD8, and the ratio, what you see is that the ratio increases, the CD4 increase, and the CD8 decrease. This is what is normal, okay? And this is up to 15 years. So in 15 years of undetectable viral load, your ratio increase, CD4 increase, and the CD8 decrease, okay? So now why I did this, why I said this? Because we wanted to test if in new strategies, and this is the Gemini trial that is the most attractive, I think. These data were presented in Amsterdam in July, and really they show that in patients with a baseline viral load below 500,000, there was no difference between in starting treatment between dolutegravir 3TC and dolutegravir plus tenofovir plus FTC. You see the same level of viral suppression. So what we wanted to see was that if decreasing the number of drugs could have an impact on inflammation using as a proxy CD4-CD8 ratio. And where we checked this? We checked this in the same cohort. We checked that we performed the other study on the ratio, that is the ICONA cohort in Italy, and we published it earlier this year. So we wanted to see if in patients switching to dual treatment or to monotherapy compared to those who were continuing triple therapy but who switched to another triple, because we wanted to avoid the selection bias. The event of switching was present in the whole population. A group switched to a triple, the other switched to a double, and the other one to a monotherapy. The number were not very big, but for the whole population was 1,241. Most of them switched to a triple therapy, 100 switched to a dual therapy, and 64 switched to a monotherapy. And these are the baseline characteristics. Really, they were well matched. The differences were obvious. Was like very few patients who experienced an AIDS event were switched to a monotherapy. Very few of them, and this is not surprising. There were less with HCV, but usually when you use less drugs, you try to use less drug in a better population than when you maintain 3 drugs. Okay, so these were the regimens that were studied. You see that most of them were with PI, and so PI with 3TC in most of the cases. And there was also NRTI sparing dual regimen with, with the use of raltegravir or dolutegravir with PIs or etravirine. And the monotherapy was with different PIs. So what we saw, and these are mean and standard deviation, then I'll show you the logistic regression. We saw that if we consider those who switch to triple therapy at 12 months, you see that the ratio has an increase, okay? While those who switch to dual therapy, the ratio was stable, you see, and the difference was statistically significant. While we had very few patients on monotherapy, so I don't think that we could reach any statistically significant results. And why the ratio was stable? It was stable not because of CD4, because CD4 was exactly the same. The increase in CD4 was the same, and no difference. So if you look at in the ambulatory, in your clinical practice at CD4, in presence of a viral load, of an undetectable viral load, you don't find the phenomenon, because the CD4 are increasing the same way. Either you switch to triple or you switch to dual therapy. The reason why the ratio stabilized, it's because there is an increase in CD8. So after you switch to 2 drugs, there is an increase in CD8. And this is at 12 months, and the same thing you see at 24 months. You see that the ratio still stays there, and there is a big difference with those who switch to triple, while the CD8 increase, while in those who switch to triple continue to decrease. Okay, and this is statistically significant, while no difference among CD4, absolutely no difference. When we look at the linear regression, you see the same results. And when you look at, this is at 12 months, you see difference in the ratio, but especially you see there is an increase in CD8 that is at 12 months, like 133 cells in mono and 186 cells per microliter in dual therapy. Is it relevant? I don't know, but this is just a datum, and no difference in CD4. Since the numbers were really at 24 months were lower, there is a trend because it's 0.060, but no significance in CD8. It still remains significant in the ratio, but there is a trend, but not a complete significance at 24 months. So this datum was also confirmed by another cohort in Italy, because I presented this data, and one of my friends who is working with the master cohort checked in their cohort, and really it was exactly the same. Here you have different, you see mostly PIs with 3TC, but there is also some dolutegravir 3TC. As we had 13, here they have 10, but not so many because they are data until 2016. So it's, what you see here is that if you look at the CD8, you have an increase, a general increase in CD8, especially in those who have, for example, 3TC and darunavir or raltegravir and PIs. So I don't know. It's something, and they say that it could be mostly evident when you discontinue tenofovir, and they didn't see it when they discontinued when the patient discontinued abacavir. I don't know. What I really think is that we need, and it's what we are doing now, a prospective trial in switch to understand not only the ratio but also which are the CD8 that could increase in just understand what is going on. Because why does it happen? We don't know. The instrument that we have to measure what is going on are not perfect. One is the HIV DNA, but we know that HIV DNA actually did not change when you use 5 drugs, like in the Optiprim, or when you use one drug in the Monarch. So it's difficult to see if there is a difference with the HIV DNA. And the other thing that we know is that when you use drugs, we use 3 drugs because efavirenz, indinavir was too toxic in the trial, and so we went for combivir indinavir, or combivir efavirenz. But there's no reason to use 3 drugs. We have seen that 4 drugs doesn't work, that 5 drugs does not work better than 3 drugs. But it's like a dogma. We are using 3 drugs like a dogma. But maybe we are doing something because we have different penetration of the different drugs, and these are, in particular, tenofovir, FTC, atazanavir, darunavir, and efavirenz in lymph nodes, in ileum and rectum and in PBMC. You see the variability of the concentration of these drugs. And this year at CROI, it has been shown that among the 3 integrase inhibitors, there is a different lymph node concentration that is, elvategravir, probably because of the booster, has a greater lymphoid concentration than dolutegravir or raltegravir. So I just wanted to show you that things are more complex than we thought, maybe, and that inflammation is still there. We don't have a lot of, we hoped that some anti-PD-1, for example, could do something on inflammation, but the side effects in our patients are very important. So we are still looking for new instruments for this, but it's important for you in your clinical practice to look at CD4-CD8 ratio, and not only to look at CD4, because some of the events are not captured by only CD4, but we don't have definitive data that one drug could work better than the other, and we have to see if new strategies could really give us more in terms of toxicity, but maybe could be harmful in terms of inflammation. Thank you very much.